So I'll be talking mainly on the DMD and its management. So DM is a specialized basement membrane of the corneal endothelium. It's resistant to chemicals, infections, and pathologic process, and the thickness is around 10 to 12 microns. So it was first described by Weave in 1927, and it was described as a potential vision-threatening complication after cataract surgery in 1964. And the incidence is around 0.044 to 0.52 after phacoemulsification and 2.6 after ECC. So the causes and predisposing factors are many. So it could be surgically induced, spontaneous, and familial. So preoperative risk factors are old age, dense cataract, corneal vascularization if there is any previous history of chemical injury, and also intrinsic DM anomalies and endothelial diseases. So spontaneous, it could be because of abnormality in the fibrillary stromal attachment to the descimase due to mutation in the TGF-beta gene. Intraoperative, it can happen in any of these surgeries, most commonly being the cataract and also in keratoplasty. So it's mainly due to insertion of any blunt instruments, inadvertent insertion of instruments or any fluids in the anterior chamber, tight main incision where the phacoprobe doesn't really fit, and also engagement of the descimase during the irrigation aspiration, IOL insertion, and also phacoprobe insertion, and whenever the ultrasound is more than 60 seconds. So there are multiple classifications of DMD. Let me just brief in short. So one of the initial classification was by Samuels. He had divided into active and passive. Another classification was by McCool and Halls. It's divided it into planar and non-planar, where planar is less than 1 millimeter separation of the DM from the stroma and non-planar is more than 1 millimeter. And there's also another classification by Dr. Susan Jacob et al. So she has divided into the ones similar to that of a retinal detachment, like the rhegmatogenous, tractional, bullous, and complex detachment. And the management algorithm is based on this flowchart. And also we have the Dua's classification. He has classified into type 1, 2, and 3, where type 1, where both the PDL and the DM is detached, and type 2, only the DM is detached, and type 3, both the PDL, predescimase and descimase is detached but separate. So whenever there is persistent corneal edema, we need to examine thoroughly, and we have to scan and look into the exact location of the DMD. So you can do ASOCT, Scheimpflug, or even UBM. ASOCT is a superior alternative because of the speed and ease of image acquisition, and you can do it in upright position and it is non-contact. So we need to thoroughly scan the area of descimate membrane detachment and plan based on ASOCT and plan for descemetopexy. So the management varies from observation to topical treatment to descemetopexy or even to keratoplasty. So this is a HELP algorithm by Kumar et al., where H is for height, E is for extent, L is for length, and P is for pupil, where the management is planned accordingly. So medical management is done when the DMD is planar, short, non-scrolled, and in the periphery. So, and when the height is less than 100 micron, length less than 1 millimeter in any of the zones mentioned in the picture. And also when the height is 100 to 300 micron with the length 1 to 2 mm involving zone 2 and zone 3, we can medically manage. We can manage by using topical steroid, hypertonic saline. You can also add rho kinase inhibitor depending on the size, and you can add cycloplegics and anti-glaucoma medication. And when it doesn't resolve in 4 weeks, you can plan for a surgical intervention. So surgical intervention quickens the visual recovery, avoids any permanent damage, and prevents the need for keratoplasty. So we can either use AIR, SF6 or C3F8. So when we plan for the procedure, we can add a pre-op pilocarpine to maintain the iris lens diaphragm. We need to take the informed consent, and we can either do it under topical or peribulbar. So there are some, let me share some tips. So one of them would be while injecting the air or the gas. So you can use a 27 or a 30 gauge needle and make sure the bevel is down, and always inject from the site where the DM is attached. And we need to wait for around 10 to 15 minutes. We can also massage to clear off any fluid between the detached DM and the stroma. And release of the air should be very controlled. So we shouldn't immediately release the air because the DM can get detached again. And when we release the air, make sure around 70% of the air bubble is left in the anterior chamber. And if you're planning to leave a full air bubble, make sure you do a surgical PI and suture the wound. That's very important. And for better adherence, we can always use an external stab incision to aspirate any fluid between the DM and the stroma. And when we inject the air, it has to be controlled. So ensure that the IOL is stable before injecting gas. So thorough pre-op evaluation is very important because there could be vitreous in AC. So whenever anyone refers a case to you with the DMD, so we need to make sure and plan accordingly. And prefer to inject one single bubble. I know there'll be multiple bubbles coming, but a single bubble would be neat and it's easy for you to look into it. And whenever you make an entry to inject the air bubble, make an entry just enough to accommodate the cannula to avoid any leaks. We need a stable anterior chamber. We can either use a 1 ml or tuberculin syringe. And whenever there is a long-standing DMD or there is a tractional DMD, make sure you do an additional procedure, that is a desmatotomy. You can always make a small nick. If there is any fluid or anything, it will drain. And if you do not do a desmatotomy in a long-standing DMD, the DM will never attach. So this step is very important. If you have access to intraoperative OCT, nothing like it. So you can have a real-time image of the DM before and after attachment. 2 minutes, please.
Just continue the slides, please.
So what if the first attempt fails? You can always re-inject the air or the gas before you plan for a endothelial keratoplasty. So the success rate is good if you do a repeat air injection. So the tamponade is better with C3F8 and SF6 compared to that of air. And also there are a few complications, that's pupillary block and raised IOP. We need to monitor this accordingly. And there are a few studies who have tried suture fixation. I haven't tried it personally. So you can do a full thickness interrupted mattress suture where you take the suture bite from the attached to the detached DM. So this is the picture of the same. And if nothing works, finally you go for a DSEC, that's endothelial keratoplasty DSEC or DMEC or penetrating keratoplasty depending on the case. So the take home message is, yes, DMD is a sight-threatening complication if not recognized on time. If it is noticed on table, manage it on table itself. High index of suspicions in any persistent corneal edema, and see to it that less manipulation is done during surgery and have a less phaco time. Management is customized according to the patient and the case, and when in doubt, the general ophthalmologist has to refer this patient. Thank you.
Thank you, Dr. Aparna. I think Dr. Elan is here. I think a lot of people, Elan, nowadays talk about PDEC. So I think Professor Amar Agrawal has been talking about that PDEC has got more advantage than DSEC or DMEC. I think since you are a cornea person, you are done from All India Institute of Medical Science, New Delhi. I think I need your some comments and opinion regarding this.
PDEC, the biggest advantage is it's easier to do. Number two, you can use any kind of tissue. Normally, we can't use a young corneal tissue for a DMEC because we can't separate it. PDEC, you can do that also. So these are the two main advantages. Coming back to DMD, clinically, if I have to look at a classification that will help in management is a Susan-Jacobs classification. Simple logic. Retinal detachment, if it is only detached, we can do a retinopexy with air or with any gases. But if there is any traction, any pull, then we need to go and cut it. She has used the same logic in providing this classification, and that's what helps us in managing these cases, actually. That was a beautiful presentation.
Thank you. I think